Good morning on this fine day, or a good day to you if you're watching this some other time that's not morning. My name is Rhiannon Parise. I am a student at Grand Valley State University. I am going to obtain my Master of Social Work, and I am in my final year of working towards it. Today, I am doing a presentation on recommendations for eating disorder treatment. This presentation kind of really revolves around the current treatment that is available to individuals with eating disorders. And then we're going to kind of be looking at why it may not be working so well, and perhaps some recommendations for how that treatment should change. So we'll dive a little bit into the history of eating disorders and kind of work our way from there. So in order to do this presentation, I apologize in advance. I'm not very tech savvy, so I will be sharing my screen. You will be seeing the presentation and you will be hearing me, but you will not be seeing me speak. I, again, apologize. I spent a good deal of time trying to figure out how to do that, and it wasn't working out. So we're going to go from there. So I'm going to go ahead and start sharing my screen. Okay. We'll head over here. So again, this presentation is eating disorder treatments and how our current approach just isn't cutting it. We're going to be giving recommendations of how to improve the current treatment. These recommendations are being given by both providers as well as clients. You'll see throughout the presentation, I did conduct some interviews. I also have incorporated some literature and some research to back up some of these recommendations. So to start off, we want to identify what are eating disorders. According to the American Psychiatric Association, they're behavioral conditions characterized by severe and persistent disturbance in eating behaviors and associated with distressing thoughts and emotions. So as we kind of go over the history of how some of these eating disorders came about throughout history, you will see that eating disorders, while they were present in very, very early times, they weren't yet associated with distressing thoughts and emotions, primarily linked to body image and things like that. So we'll get into that in just a moment. The types of eating disorders available according to the current DSM-5 are anorexia nervosa. That is the eating disorder that primarily focuses on restrictive food intake with a BMI that is extremely low. Then we have bulimia nervosa, that is characterized by binges and then some sort of compensatory behavior. Now that behavior can either be restricting your food intake, it can be over-exercising, it can be purging in the form of either vomiting or laxatives, things like that. We also have binge eating disorder. That is the disorder that is identified by binges and then not necessarily any correcting behavior following that binge. We also have avoidant restrictive food intake disorder, eating disorders not otherwise specified, pica, and rumination disorder. So eating disorders over the years, we first see them pop up in the Middle Ages. There was anorexia mirabilis, which really was focusing more on a spiritual cleanse. It did not have any connection or ties to a body image or an ideal body shape. Then in the 1500s, throughout the 1800s, we see miraculous maids. This is a focus on extraordinary ability to starve for spiritual and material beliefs. So again, kind of that same idea that we first saw pop up in the Middle Ages. However, it is starting to lead into the ability to starve for greater lengths of time. Then in 1858, we see hypochondriacal delusion due to dyspepsia. So this is self-imposed food refusal with somatic functions. Then in the late 1800s, that's when we start to see the anorexia hysterica. This is the self-imposed food refusal with the romantic ideal of a pale, languid body. This is extremely important. This is when we first start to see that restricting food intake is starting to be tied into, I'm doing this for the purpose of changing the shape of my body, with the romanticized idea that I will have a ideal body shape. So this is really where we begin to see food disorders or eating disorders, anorexia, being seen as a psychological disorder. So then throughout the years, we jump all the way forward to 1950s and 60s. This is when anorexia nervosa is the first eating disorder to be classified in the DSM. So this is food refusal, considered to be a psychophysiological reaction. And then we go ahead in the 1970s, we see anorexia, pica, and rumination. So those start to become added into the list of special symptoms of feeding disturbances. We don't see bulimia nervosa pop up until the 1980s. Not to say it wasn't occurring well before then, but this is when it is finally added as a diagnosis into the DSM. And then in the 2000s, all the way up to the 2015 year, we see emerging trends in eating disturbances, hence all of those other definitions of eating disorders that are now classified in the DSM as of the year 2020. So here's some statistics I have kind of pulled from the National Association of Anorexia Nervosa and Associated Disorders. Eating disorders affect at least 9% of the population worldwide. 9% doesn't seem like a significant percentage until you also consider there's 7 billion people in this world. That is pretty significant. So 9% of the US population, or 28.8 million Americans, have an eating disorder in their lifetime. You will see that typically the prevalence of eating disorders pops up throughout adolescence as well as young adulthood. However, it's not primarily restricted to that age group. You can see it throughout late adulthood. You can see it well into the older years. Less than 6% of people with eating disorders are medically diagnosed as underweight. So being diagnosed as underweight means that you have to reach a certain body mass index. In all of the eating disorders that are currently identified, the only one that has criteria to reach a certain body mass index for the diagnosis is anorexia. 28 to 74% of risk for eating disorders is through genetic heritability. So this is a genetic thing. No one really knows for sure the exact cause of eating disorders, but research has shown that there is a genetic factor to the risk of developing an eating disorder. Eating disorders are among the deadliest mental illnesses, second only to opioid overdose. The really significant thing here too is that eating disorders are not only a medical diagnosis, a medical complication, because we are, when an individual has one, they are putting harm to their body, but they are a mental illness diagnosis. Because they are behavioral, and these behaviors are a thought process that cause us to engage in them. You will actually find too, with out of all the eating disorders, anorexia nervosa actually has the highest rate of suicides out of all eating disorders. So 10,200 deaths each year are the direct result of an eating disorder. That's one death every 52 minutes. Again, when we see numbers and statistics, it does not sound very significant, but taking into account that time frame, it has a greater impact. And then about 26% of people with eating disorders attempt suicide. So some causes of eating disorders, they are identified to be a mixture of biological, environmental, and mental factors. Some particular risks that an individual will develop an eating disorder is if the family has a history of eating disorders. Females are particularly at risk, as is the adolescent or young adult age group. if you were exposed to diet culture, especially in the younger years, but anytime throughout your life, you're more at risk. There also is a correlation between childhood abuse, both physical, mental, and sexual, and a later development of an eating disorder. And then eating disorders are very often co-occurring with other mental health or substance use disorders. So another cause, which was discussed by Carolyn Knapp, there I'm missing an N in her name in there, but she wrote an amazing book called Appetites, Why Women Want. And in her book, she seeks to answer Freud's question, what do women want? Carolyn takes on this really, really beautiful framework and narrative that throughout history, women have been told that their appetites need to be restricted primarily to the literal definition of an appetite linked to hunger, and that they have to focus on that more than anything else. That's kind of like a societal portrayal of what women should be focusing on. So they're not really encouraged to explore their deeper appetites being, what do I want to accomplish with my life? Personal experience with eating disorders, not as a way to maintain weight. This is coming from Carolyn herself. She identified that with her years of battling anorexia, she was not trying to necessarily get to a certain weight, although that certainly was part of it. But she explains how her anorexia primarily came about as a way to cope with her anxiety or underlying mental illnesses. So it was a coping mechanism because she, as she explains it, if she's so anxious and concerned about gaining weight or losing weight, then she doesn't have to focus on the anxieties that are greater in the world. She also explores the concept that food intake and weight have been directly correlated to sexual desire throughout history. Again, we saw that in the 1800s when anorexia began to be connected to the ideal image or body shape of a woman. So in order to feel wanted, women need to eat less food and have that ideal body shape. She also takes on a very beautiful and strong feminist viewpoint that women are encouraged both subliminally and explicitly to focus on physical appetite rather than dive deeper into their wants, desires, or appetites. What fills our hearts? What do we want to accomplish in our lives? Very great book. I recommend everyone read it. So in my interviews that I conducted for the sake of this project, I kind of interestingly enough, I switched what I wanted to find after I started conducting the interviews because of the information that came out. So originally in the beginning, when I started these interviews, I aimed to address the challenges of involuntary placement for eating disorder diagnoses and mental health treatment, because involuntary placement for eating disorder diagnoses is so controversial because again, they are extremely similar to, say, a substance use disorder, where in order to create a lasting change or to diminish the impact of that disorder, the individual has to have some insight or want to change. So like with substance use disorders, eating disorders are very similar in that the individual has to want to get better. So I really wanted to dive deep into how are we accomplishing this by involuntarily placing someone who doesn't want to change? Also, eating disorders are relatively new, meaning we didn't see the boom of all of the different types of diagnoses for eating disorders until about the 1950s, going into the 1980s. So because they are so relatively new, they're not yet commonly seen as a mental health disorder. So again, just to recap, wanted to identify how we could possibly improve this based on the fact that involuntary placement for eating disorders is pretty controversial. So some of the interview questions I asked, I conducted 3 interviews. I wanted the individual to identify the role that they had within the interview, either as a provider or a client being an individual that either was in partial remission or complete remission of an eating disorder. I then wanted to ask them, what has been your experience with eating disorders, either professionally or personally, based on the role that you have in the interview? I wanted them to identify the biggest challenges with eating disorders and treatment based on their thoughts, experiences, and knowledge of those eating disorders and the treatment provided. Thoughts on involuntary placement as it relates to mental health. Is it effective in the long run? Is it efficient in keeping someone safe? And then to wrap up the interviews, I wanted their recommendations on how eating disorder treatment could be improved. And then, are there any barriers that the eating disorder demographic faces? Is there any implications? So, interviewees from multiple perspective. Provider one is a clinician determining the need for treatment. Provider two is the clinician providing the treatment, and then the client, the one receiving the treatment. So those are the three interviews that I conducted. Provider one, clinician determining the need for treatment. This was done by a Mr. C. Madden. So throughout our interview with him, just to clarify so that I'm able to portray how his process goes about. So this is a clinician that has a case and assesses an individual either in the emergency room or from another provider, and is given the case to determine, does this individual need immediate placement in an inpatient psychiatric unit? Do they need inpatient mental health hospitalization? That can either be at a hospital, or it could be at something we call a crisis residential facility, which is not as restrictive. It's not locked. However, for the sake of this particular interview and study, we were focusing primarily on eating disorders and their need for inpatient hospitalization, meaning they would be forced to receive treatment. So strictly through hospitalization. So what came about over our course of the interview is that inpatient treatment may be necessary for eating disorders based on the imminent risk to self and based on their mental health. By that, we mean that the eating disorder has become so great that the individual is very likely within the near future to either harm themselves to the point that it is debilitating for the rest of their life, or may end their life. It's also important to consider that eating disorders are lethal and often co-occurring with other mental illnesses. So we did, throughout our discussion, kind of identify that it is difficult sometimes to identify what is the eating disorder diagnosis and what is the other co-occurring mental illness. That can either be depression, it can be anxiety, it could be something greater than that. But either way, Mr. Madden's job was to determine the eating disorder and mental health in general is causing this individual to put their life in danger. Some of the challenges of determining the treatment necessary for an eating disorder is the lack of specific eating disorder treatment. Also, that involuntary treatment is not the only treatment needed. It's important to consider that the family be involved as well. So we did touch base on the fact that a lot of times, even if an individual is receiving treatment in an inpatient facility, that's not the only treatment they need, right? Because as soon as they go home, then a lot of times there may be this familial struggle between either adolescent and parents, or wife and husband, what have you. It's one person saying, you know, I don't want to, I can't eat because of whatever reasons I have, but I can't eat. And then the family is also just kind of butting heads saying like, well, I don't understand why you can't eat. It's just eating food. It's not that hard. It's so primarily, I mean, treatment needs to be provided not just inpatient, but it also has a wide spectrum of ways that treatment needs to be provided. So involuntary placement has not shown to create lasting success or long-term change. Eating disorders are similar to substance use disorders. This is a behavior. The individual needs to want to change in order to be more successful. So in order for an individual to want to change, they have to have some level of insight, meaning they see that the behaviors that they are engaging in are harmful and that there's reasons that it needs to change. So because of this, involuntary placement, putting someone in treatment that they don't want treatment in the first place, it's very difficult to do that. And then they leave the facility and they go right back to the same behaviors that they were demonstrating before. Of significant note too is that typically with this, I mean, involuntary placement can be controversial too, in that if an individual is being placed and they didn't want the treatment in the first place, this also may have a longer lasting effect, that the individual no longer has that rapport or that positive relationship with treatment providers because they were placed involuntarily. And that's something we see not only with eating disorders, but any other mental illness or mental disorder that is requiring involuntary placement as well. Another topic that came up is that schools would be a beneficial place to start teaching EDs as an intervention before young adulthood. So just providing that education so that people understand what these are, and that they can be sneaky, and before you know it, you may have one. So the second provider, this is the clinician providing the treatment. The individual I met with for this was a Mrs. P. Smith. So in our interview, some of the key points that came up is that treating eating disorders needs to be comprehensive, which I kind of touched based on in the previous slide as well. Not only is this like the treatment you're getting in the facility, but there's also the family-based therapy. The individual needs to have a primary care physician for the medical complications with eating disorders, a psychiatrist if any mental health medications needed to be prescribed. A therapist is beneficial as well because, like I said before, they are often co-occurring with other mental illnesses, and sometimes talking about that or just diving to the root of the problem is beneficial to the patient as well as a nutritionist. It says nutritionism, it's supposed to say nutritionist. I apologize for that. But the nutritionist can also provide a good framework for where to start as far as how we consume food and what foods would be best to support our bodies, hence the PCP, seeing them because of the medical complications where an individual may not have been doing that before. We also discussed that there needs to be some work on body positivity. Sometimes compliments are meant to be positive, but are actually harmful. For example, an individual that tells someone else, "Wow, you look amazing. You've lost weight. You didn't look like this before. You must be working really hard." This may be reinforcing to a, say, bulimic woman who continues purging behaviors. So, an individual that is losing weight, they may be losing that weight in a negative way. And so for someone to acknowledge, "Oh my gosh, you're looking amazing," just tells an individual, "Oh, so these behaviors are working and I should continue with them." Another example would be a workplace holding a weight loss challenge over the holidays, which reinforces that losing weight is equivalent to being healthy. That is not the case. Each individual is different. Their body composition is different. We all work in different ways, and what may be healthy to one individual may not be healthy to, say, myself or you. Another point that came up is that education early on is needed in schools in order to prevent eating disorders as opposed to stopping them. So we did discuss a lot about how eating disorder treatment currently available is very reactive. These individuals already have them. However, in order to kind of get a jump on how we treat these would be a preventative approach, meaning we're providing that early intervention or that early education in schools before these individuals begin to develop them. We also, interestingly enough, discussed the need for research into the LGBTQ plus in eating disorders based on the body transitioning. So this is something that is also, again, relatively new to this demographic with LGBTQ plus community or demographic too. That particular group is already going through such a significant body change, or I say they might be, not every individual, but some of them may be. There may be that transitioning process. And as women, their bodies are composed of primarily holding more fat than typically men do. That can provide a negative impact on an individual that may support some eating disorder behavior. We talked a bit about more about this. Mrs. P. Smith, who is a registered dietitian, definitely provided some really great talking points on this. And it's something I hadn't considered yet before too, again, because this is such a new topic. But she did really provide some support for the fact that peer support has been shown to be greatly beneficial in this treatment for this group, rather than focusing on the eating disorder. So just to kind of recap that, an individual in the LGBTQ plus community that has an eating disorder, sometimes that treatment that needs to be provided may not be eating disorder specific treatment, just because of that transition that an individual may be going through with their body. It has been shown that peer support, someone to talk to about that transitioning process and getting experience from another individual, may be a more supportive type of treatment rather than eating disorder treatment specifically. So the third individual that I interviewed, this would be the client perspective, the one receiving the treatment. I met with a Miss, pardon me, E. Richards. So in our discussion, we kind of talked about her eating disorder that she had battled for about 6 years, and kind of her ideas and insight as to, from the perspective of someone who has an eating disorder, what were her challenges and experiences dealing with the individuals that were either determining need for treatment or providing treatment, and then the actual treatment that she received. So some of our key points were that placing someone who doesn't want to be placed, results can go either way. Either it's a wake-up call that their behaviors have been problematic and are very detrimental to their health and well-being and they need to change, or they become so angry and are just so blind to the fact that this treatment is needed that this only adds fuel to the fire and reinforces the behavior as a way to either rebel, or we did discuss too, someone may just be so ill that they don't necessarily see it as a way to rebel, but just a way of living because they see it as healthy. But she did make a really good point that sometimes too, when you have someone telling you like, hey, this is bad, you need to stop, an individual that is in such great denial, and also again, specifically individuals that have that family stuff going on at home where their families aren't necessarily wanting to work with them or hear them out the way that they may need, well, that may just drive them to engage in the behavior even more. Another key point was that inpatient treatment is not as supportive as some may believe. So we spent a good amount of time about her experience. She had been hospitalized for her eating disorder twice. The first time involuntarily, the second time voluntarily. Her parents brought her and she was more willing to go that second time around. But that was, I believe she said, 3 years after the initial inpatient hospitalization that was involuntary. So she made some really good points about her first stay there when she was still very ill and had no insight to the need for treatment or the need to change her behaviors. So she made a really good point that other individuals that are in the same boat as you when you are inpatient hospitalized, they don't want to be changing their behaviors either. They're just as ill as you. They're also engaging in similar behaviors. So she said that within the first week of her inpatient hospitalization, she had actually met with this girl that was giving her tips and tricks essentially. And they both did that. They exchanged their tips and tricks for how to behave in their eating disorder behavior, either purging or exercising or whatever that behavior was. And she actually left that hospitalization with more arsenal in her pack, so to speak, than she had going in. So she said, she made a really good point that in some ways this treatment is not as supportive of as one may believe, because while you have the clinicians, providing the treatment as far as how the eating disorder should be eradicated or improved, you equally have just as many patients in there that can provide information going the opposite way. The third point that she made was that there is little to no early on education about nutrition and how to balance diet or exercise, how to eat in moderation, that there are no good or bad foods. This is a failure in the school system. So again, this is another individual that was able to identify that in school, you're not really taught really what quote unquote healthy relationships with food look like, or how diet and exercise aren't necessarily an extreme to lose weight, but they're just a balance that keep us, again, quote unquote, healthy. So also touching base on the no good or bad foods, that's a difference in the way we talk about our relationships with food that needs to change. Way too much the good foods are seen as the healthy foods, which are, salad, fruits, vegetables, things like that. And then the bad foods are very sugary or fatty foods like chips, cakes, things like that. And really that idea is causing more harm too than good. There are no good or bad foods. It's all about balance. So consistencies across the board throughout all of these interviews. These are the themes that kind of came up in each and every one. Involuntary placement works for immediate safety, meaning this individual is not going to engage in behaviors that are going to cause them to end their life or harm them further. However, they do not work well for long-term treatment, meaning they're not very supportive for the individual to be eradicated of the disorder in the long run. Another one is that in some instances, involuntary placement can be more harmful than good. Again, we saw this with the fact that rapport can be ruined by a client and provider, meaning that if they're placed involuntarily when they didn't want to be, then they may have a negative view of treatment providers in general and not want to engage in that treatment. Or, you're placed and you meet another individual that provides you information for how to further engage in your eating disorder. Another point is that the current treatment available is reactive rather than proactive. Again, tying into that last bullet point too, improvements to treatment should focus on early interventions, meaning providing more education in schools, because right now the treatment is providing a disorder that has already developed and there's little to no support to prevent the disorder from spreading. Okay, so then diving into some of the current research that's out there, these are some statistics I pulled from a few studies. The first one is that involuntary placement results are mixed. 50% of individuals reported full recovery after involuntary placement. 30% reported partial recovery with a relapse within the next year, and 20% report no improvement. This was pulled in 2017. So a few years ago, but still pretty supportive of what seems to be the viewpoint of providers today. The second one is that when comparing mortality rates, one study found that mortality rates were 12.7% for involuntary patients, whereas rates were at 2.6% for voluntary patients at a 5-year follow-up after hospitalization. So by this meaning that 12.7% of individuals did result in death. I did not see in the study what type of death that was caused by, whether it was a health complication or maybe loss of life to suicide. However, that is a pretty substantial, about 10% increase as opposed to individuals that went to patient voluntarily. The third one is that a significant number of individuals with eating disorders will not seek treatment unless legally compelled to, meaning they are court-ordered to receive treatment, hence the involuntary placement. So ethical considerations of providing treatment to an individual with an eating disorder from the social work perspective. These are considerations taken from the National Association of Social Workers, or NASAW. Ethics 1.01 is commitment to the client. So the client's interests are primary to the treatment. However, there's an exception in the event that they are inflicting pain on themselves or others. So again, this is kind of tying into why involuntarily placement may be needed, and actually why it by definition is not unethical, that we need to make sure that the client's well-being comes first and foremost. So really, that would be primary to the treatment, except when the client's interests align with that. Ethic 1.14, clients who lack decision-making capacity. Social workers will make informed decisions for the client when they do not have the capacity to do so. Again, tying into the involuntary placement ideal of this. When an individual does not have the mental capacity or say the reality testing to be able to make an informed decision, they don't see why this behavior is problematic, then the social worker does have the ability to say, well, I'm going to need you to do this because it is important. Important meaning, not just like, oh yeah, you should do this, but important meaning you need to do this in order to continue living. Ethic 1.16, referral for services. Social workers should refer to clients to appropriate services that are outside of their scope of practice and ensure they are set up with those services accordingly. So again, when a social worker is seeing that a client may need this type of service and we're not able to provide it, we need to ensure that they are being set up with that service, i.e. eating disorder specific treatment. And then ethical consideration 6.01, social welfare. Social workers should promote the welfare of society and promote social, economic, political, and cultural values. So I pulled this one because I do think this kind of comes into play with the early intervention aspect of eating disorders and why social workers should be promoting this education early on in schools to promote the welfare of society and limit the number of eating disorders that seem to be occurring. So where do we go from here after taking all of this and compiling it? What are some of the recommendations for what should be done for current treatment that is available to the eating disorder population? So first and foremost, we need to begin to implement ED prevention. Again, this was something that was pretty consistent across the board with all three providers and or clients, is that early education in schools for nutrition, for eating disorders, for a balancing diet, exercise is really needed. We also need to emphasize body positivity and self-esteem, especially in those early years, linking, the ideal body shape to what is healthy. We need to reframe that idea of what is healthy. Everybody's body's different. Everybody has different dietary restrictions and their metabolisms work differently. And we just really need to be promoting that positivity, that there are different shapes and sizes of individuals, all of which can be considered healthy. Second, inpatient residential treatment specific to eating disorders. So treatment team of providers well-versed in eating disorders and how best to treat them. Again, that team that I mentioned earlier, as far as a primary care physician, a therapist, a psychiatrist, a nutritionist, all of those things, they need to have that education of how to treat an eating disorder. And then also put less emphasis on involuntary treatment as it ruins rapport between client and the treatment in general. Again, when a person is involuntary placed, it is because they are within near immediate danger of either ending their life or creating some sort of harm or danger to themselves that would be irreversible. However, involuntary treatment really just is shown not to be as efficient, and in some cases could be argued even more harmful. I know that there is one that is popping up in Michigan alone. I cannot recall off the top of my head, but there is a residential eating disorder treatment facility that is popping up in Michigan in April of 2022. Otherwise, the only other one that's offered right now is the Forest View eating disorder treatment. And that's just one floor or one treatment option for inpatient eating disorder treatment in an entire state. It's really not meeting the need that's out there. And then there's a list of our resources. So that is pretty much my entire project and everything that I pulled together for the sake of how eating disorder treatment should be improved. I am very much open to any ideas or comments that you have after watching this and listening to everything I have to say. Just want to impact or leave with you guys that currently what we're doing is not stopping the spread or prevalence of eating disorders, and it does not seem to be offering pretty substantial treatment to fixing them or eradicating them, whichever terminology you would like to use. But really, again, want to focus on that early intervention and providing treatment that is knowledgeable of how to treat an eating disorder. Thank you.